My name is Aaron Gerds, and I'm the editor-in-chief of ASH Clinical News. I'm joined today by Dr. Locke, who presented data at this annual meeting on CAR T-cells in large cell lymphoma. Thanks for joining us today, Dr. Locke.
Thanks, Aaron.
All right.
Appreciate it.
So I loved your abstract. It was wonderful to hear about all the wonderful work you've been doing with CAR T-cells for patients with lymphoma. My first question is about treatment space with CAR T-cells. CAR T-cells are already approved for lymphoma. Why do we need this trial?
Yeah, so CAR T-cells are approved. We actually have three products approved for treatment of patients who need a third line of therapy or later. These are patients with large B-cell lymphoma. Those are all based on single arm phase 2 studies. And so in order to sort of prove the efficacy, you need a randomized trial. And also this trial, the ZUMA-7 trial, is moving up the therapy into the second line. And so we're testing out CAR T-cell therapy, in this case axicabtagene ciloleucel or Axi-Cel, as a second line therapy against the current standard of care, which is a multi-step treatment paradigm that consists of multi-agent chemotherapy, and for patients who respond, high-dose chemotherapy and consolidative transplant. And so the question we had in ZUMA-7 was, if you're a large B-cell lymphoma patient who needs second-line therapy, can you get CAR T-cells as your next line of therapy? And if so, will that do better than that treatment paradigm I described?
So these are patients who had lymphoma, got initial treatment with, say, R-CHOP or something that's common, relapsed, and then went on to trial.
Yeah, so in the ZUMA-7 trial, we were interested in those patients who really had poor outcomes. And so patients, as you say, who got frontline chemotherapy and either were primary refractory to that treatment or relapsed within 12 months of that initial chemotherapy. And we know that most patients do relapse, who are going to relapse within 12 months, but those are really the patients who have poor outcomes. And so that's who was eligible for the study.
So clearly this was a positive study, really demonstrated the benefit of CAR T-cells in this space. But, kind of on the flip side, there's toxicity with any treatment that we do. Can you describe some of the common toxicities you saw with Axi-Cel on this study?
Yeah, so look, the therapy is not a light therapy, but at centers that are administering it, we're very familiar. And the common toxicities we see with CAR T-cell therapy, at least in the acute phase after the cells are infused, are cytokine release syndrome, which is characterized by high fever, and then more rarely low blood pressure and oxygenation, low oxygenation in the blood. We saw cytokine release syndrome in over 90% of patients in the Axi-Cel arm, and that really means they had a fever, right? But severe cytokine release syndrome, which we call grade 3 or higher, which really means patient needed pressors or needed to be on a ventilator, was only seen in 6% of patients. So a low percentage, but generally we feel these are manageable and we're able to get patients through. The other main toxicity that we see is called neurotoxicity, and neurotoxicity was seen in about 60% of patients with Axi-Cel, and severe neurotoxicity was in about 21% of patients. But both of these categories, cytokine release syndrome and neurotoxicity, are self-limited in almost all cases, and we're able to manage it with corticosteroids or a drug called tocilizumab and kind of keep things calm down, and the patients come out the other side and do quite well.
So the comparator arm, the standard of care chemotherapy, is obviously very different than Axi-Cel treatment. Mm-hmm. How would you describe the differences between toxicity in the two arms?
Yeah, so certainly we saw differences in toxicities. When you get as you know, when you get a multi-agent chemotherapy regimen, you can have low blood counts. In particular, when you get an autologous transplant, you can have very low blood counts, neutropenia. Neutropenic fever was much more common in the standard of care arm, but there weren't those cytokine release syndrome events. There were some neurotoxicities, as you'd get with chemotherapy, neuropathies mostly. So it's true that the two arms had different types of toxicity, but the overall rates of adverse events, serious adverse events, were very similar between the two arms. Just the nature of those toxicities were different.
Well, thinking about going forward, so if there's added benefit for CAR T-cell therapy in this space, but toxicities are comparable to standard care chemo, how do we incorporate this into everyday practice?
Well, I think what's key, especially for community oncologists and the community at large, is to understand that to get CAR T-cell therapy, we have to consider it and refer the patient very early. So I think, if you have a large B-cell lymphoma patient who's getting frontline therapy and they're not responding in the way you'd like them to, or they relapse, you need to very rapidly get them to a referral center, because we've shown that as the very next treatment, CAR T-cell therapy appears to outperform. It does outperform that standard of care treatment paradigm that we have. So we just need the patients referred, and the treating centers can do the rest.
So I assume this will make its way into the various guidelines and practice templates and care paths, but it really sounds like referring for CAR T cells is kind of like voting in Chicago. Do it early and do it often.
Do it early, do it often, and I would also say 30% of the patients on the study were elderly. Don't make assumptions about whether patients can get through this. We're very comfortable treating older patients, even patients with comorbidities, with CAR T-cell therapy. So let the treating center make those determinations.
Well, thank you so much for joining me today,
Yeah.
Dr. Locke. This has been a wonderful conversation. Thank you, audience, for watching. If you'd like to view Dr. Locke's abstract, it is on the Blood Journal website. You can reference his abstract for the data provided there. Again, thank you very much, Dr. Locke, and I hope you have a great rest of your meeting.
Thank you so much. Appreciate it.
Thank you.